The diagnosis and classification of mental illness is quite challenging and has changed dramatically since the middle of the 20th century. One key change is that mental health disorders used to be defined in terms of deviance, and critics argued that this was used by the establishment to categorize and control people who didn't fit in with social norms. Now mental illnesses are defined using the term maladaptive, which means that a person's patterns of thought and behavior are leading to significant distress and difficulty functioning in daily life. For example, to be given a diagnosis of persistent depressive disorder, the person's depressed mood must be sufficiently severe to cause significant distress or to produce significant impairment in social interactions, work performance, schoolwork, etc. We don't want to say that someone who has a particular personality profile is suffering from a mental illness. And we don't want to use the label mentally ill to marginalize or institutionalize people who are simply different. The classic 1973 study by David Rosenhan played a major role in a shift toward more reliable and appropriate diagnosis of mental illness. Rosenhan recruited 8 pseudo-patients, including Rosenhan himself, a grad student, 3 psychologists, a pediatrician, a painter, and a housewife. Each pseudo-patient called a psychiatric hospital for an appointment and briefly faked auditory hallucinations. They simply said, "I hear unclear voices in my head saying things like empty and hollow and thud." They had no history of mental illness, and apart from using fake names, they didn't lie about any details of their lives. All 8 pseudo-patients were admitted and diagnosed with either schizophrenia or what we would now call bipolar I. They acted as normally as possible once they were admitted, but not a single hospital realized that they were actually sane. It took between 7 and 52 days for each pseudo-patient to be released, with an average stay of almost 3 weeks. The only way that they were able to get released was to admit that they were mentally ill and agree to take medications. In a second part of the study, Rosenhan informed a well-known psychiatric hospital that he was going to have some pseudo-patients try to gain admission. He didn't actually send any pseudo-patients, and yet this hospital incorrectly concluded that 41 people who were actually seeking admission were pseudo-patients. This reinforced the conclusion that the doctors and staff at psychiatric hospitals couldn't really tell when somebody had a mental illness. This just couldn't happen today. First, our mental health treatment systems are now designed to get people out of the hospital as soon as possible. People are discharged if they're no longer floridly psychotic and pose no danger to themselves or others. Second, we now have very effective antipsychotic medications that provide full or partial reduction in hallucinations and delusions in at least 70% of people with schizophrenia. Third, the Diagnostic and Statistical Manual of the American Psychiatric Association has been refined over the years to provide much more objective and reliable diagnoses of mental illnesses. To be diagnosed with schizophrenia, someone must have multiple positive or negative symptoms for a significant portion of a 1-month period, have a marked reduction in daily functioning, and have continuous signs of disturbance for at least 6 months. Diagnosis is still far from perfect, but it's much better than it was in the 1970s. Now let's turn to some of the main classes of psychological disorders. We can start with the distinction between internalizing and externalizing disorders. This isn't a formal part of diagnosis, but it's a useful way of thinking about different kinds of symptoms. In internalizing disorders, the most problematic symptoms are the internal thoughts and emotions of the individual. Common examples are anxiety and depression. In externalizing disorders, the most problematic symptoms are the external behaviors. Common examples are ADHD, oppositional defiant disorder, conduct disorder, antisocial personality disorder, and drug and alcohol use disorders. The DSM defines a huge array of different disorders, and I've focused mainly on mood and anxiety disorders and on thought disorders. Make sure that you review the personality disorders and the childhood disorders described in the textbook. Common anxiety-related disorders include the many types of specific phobias, social anxiety disorder, generalized anxiety disorder, obsessive-compulsive disorder, and post-traumatic stress disorder. Everyone feels anxiety occasionally, but in these disorders, the anxiety and resulting behaviors are maladaptive. They cause the person significant distress, or they lead to significant impairment in everyday activities such as work, school, or social activities. Now let's turn to depression. Everybody feels a little depressed every now and then, but major depressive disorder is way beyond feeling a little blue, and it might not even involve feelings that we'd ordinarily associate with depression. In some cases, it involves depressed mood for a long period of time. But in other cases, there isn't a depressed mood, but the person has lost interest in the activities that they ordinarily found enjoyable, or no longer get any pleasure from them. For me, this would mean that I just wasn't interested in eating chocolate anymore, or I no longer enjoyed riding my bike. So, someone can be suffering from major depressive disorder without actually feeling a depressed mood. However, the depressed mood or loss of interest or pleasure in activities must be beyond the normal fluctuations that we typically experience, and it must last for at least 2 weeks. In addition, the person must have a total of at least 5 of the symptoms on this list. Fortunately, episodes of major depression don't last for more than 3 to 6 months in most people. However, some people suffer from a related disorder called persistent depressive disorder, or dysthymia. In PDD, the depression isn't typically as severe as in major depressive disorder, but it lasts for at least 2 years and often 5 or even 10 years. Bipolar disorder is also classified as a mood disorder. In bipolar 1, people experience manic episodes that are extremely severe, often requiring hospitalization. Many, but not all people with bipolar 1 also suffer from periods of depression, but it's the mania that defines bipolar 1. Bipolar 2 involves hypomania instead of mania. Whereas a true manic episode often involves hallucinations and delusions, a hypomanic episode often involves high levels of productivity and creativity. To be diagnosed with bipolar 2, an individual must experience episodes of significant depression as well. The person may have weeks or months of depression, followed by a week or two of hypomania, and then go back to depression. Now let's review thought disorders, which are characterized by thoughts that don't match with reality. Schizophrenia is the most common and severe. To be diagnosed with schizophrenia, someone must suffer from delusions or hallucinations or have disorganized speech. Here's an example of disorganized speech from an actual patient. This type of speech is sometimes called word salad, a bunch of words tossed into random order. People with schizophrenia may also exhibit disorganized behavior, such as wearing completely inappropriate clothing for the weather, shouting at people for no apparent reason, or engaging in silly or bizarre behavior. Negative symptoms such as flattened affect and social withdrawal are also typical in schizophrenia. A schizophrenia diagnosis requires at least 2 of these symptoms for a significant part of a 1-month period, along with significantly impaired social or occupational functioning and some significant disturbance over a period of at least 6 months. The good news is that the positive symptoms, like hallucinations, delusions, and disorganization, are significantly reduced by antipsychotic medications in at least 70% of patients. The bad news is the medications don't do much to help the negative symptoms or the impaired cognition that typically accompany schizophrenia. Also, the medications have side effects, and the patients will often go off their meds once the positive symptoms have subsided, leading to another major episode of psychosis. This can now be reduced by means of slow-release injectable antipsychotic medications.